Good morning, everyone. I'd like to call to order our subcommittee on behavioral health. Welcome, everyone. We're continuing kind of our learning on all things mental health, or as much as we can. Today, we're going to be focusing on substance use and substance use abuse treatment. We are very, very lucky to have 5 different providers from across our state who do this work in lots of different ways, and we're going to be able to learn from them, hear the different ways, not only the way that their agencies and organizations work, but how they interact with one another, and also hopefully hear about what else they need so that we can understand as we're trying to make decisions and policies what we need to do. So thank you to everyone for being here, and we have some folks online. Why don't, Madam Clerk, would you take the attendance so that we know who's here?
Chair Braybeck.
I'm here.
Representatives Arbit.
Here.
Pohutsky.
Here.
Glanville.
Here.
Edwards.
Here. Present.
McDonald.
Here.
Reingans.
Present.
Schmaltz.
Here.
Hoadley.
Here.
St. Germain.
Here.
Thompson. Madam Chair, you have 10 members present. You do have a quorum.
Thank you so much, Madam Clerk. Rep. St. Germain is going to approve and adopt the minutes approve the minutes for us, and we will adopt those. Thank you so much, Rep. Appreciate that. And can we just do the absent members now? Yeah. Okay. And Rep. McDonald moves to excuse all absent. Well, Rep. McDonald moves to excuse absent members. Rep. Thompson can't be here with us today. And so thank you, Rep. McDonald. We appreciate that. And now let's get started. I'd love to be able to call folks up. Sam Price is the president and CEO of 1016 Recovery Network. We're going to have kind of first group of 3. Ronnie, do you want to come up too? So Ronnie Tyson is the clinical director of Odyssey House. Sam is from Midland. Ronnie is from Lansing. We also have Greg Toutant, who's on Zoom with us, and he is the CEO from Great Lakes Recovery Centers in the UP from Marquette. So welcome to the 3 of you. Thank you for being here. And Sam, I'd love for you to take it away.
Great. Thank you very much.
Thank you.
Thanks again, Representative Chair. Honored to be able to speak with all of you and discuss some of the great things that are going on in our space, as well as some of the challenges that we are facing. Our organization, 1016 Recovery Network, is a private nonprofit. We have staff who are in 20 different locations across 10 counties in the mid-Michigan area as far as
Thank you.
better?
That's much better. Thanks.
Thank you. So our organization does prevention in the schools. We have a collegiate recovery program on 4 different campuses. We have embedded recovery coaches in 10 different emergency departments. We offer recovery housing. We offer residential services. We have staff embedded in 2 federally qualified health centers. And we operate 4 outpatient recovery centers. So we have a broad continuum of care in order to really try and serve the full spectrum of services that are challenged. We're also a active participant in a new pilot called opioid fatality review teams, much like a child death review process. There is some pending legislation that we'd love you to take up at some time. Quick little side note, that's not in my notes, but for now, we have a prevention license that's soon to be sunsetted by Lara in the coming administrative rules, but for now we have prevention licensure. We have licensure for treatment and recovery supports for our residential programming. We're nationally accredited by CARF. Our recovery housing is accredited by the Michigan Association for Recovery Residences. So, and additionally, myself and Greg and Ronnie here are all members of the Provider Alliance's SUD subcommittee. So not only are we bringing our expertise and experience from the field, but also from our members. We discussed with them this opportunity on Monday and collected kind of their universal input on stuff. So across the board, our footprint is pretty representative of the entire state in terms of the different needs and challenges that are faced right now. So we appreciate this opportunity to kind of come before you, and let's kind of dive right in. In terms of the SUD crisis in specific, one of the things, as you know, we're all well aware that we have been in the midst of an extended opioid crisis for a number of years. I would venture to say that we have moved well beyond an opioid epidemic, and from our perspective, we are moving into more of a drug poisoning crisis instead. Because what you know, or what we've seen over the last 3 years in particular, the fatalities, 70% of those fatalities have involved fentanyl in those substances. So that is so much stronger than just traditional street heroin, if you will. And with the addition of xylazine coming into the street product, there are more and more citizens that are vulnerable when they're in their active addiction than who we are trying to address and get in front of just 5 years ago. This is not just the opioid naive or somebody who's had a recent extension of abstinence who we're talking about. This is anyone and everyone that is doing any level of experimentation or regular use that is at risk now. That needs to change then our strategies and what we're trying to do and how we're trying to work on that front end of things. But I would also go on to say that the opioid epidemic has also in some ways masked a broader addiction epidemic as it relates to really all substances of misuse. Alcohol is still far and away the #1 cause of fatalities in our state and in our country. It doesn't have immediate passing like an opioid overdose would, but it still causes the most problematic issues. And like for our staff that are in the emergency department, 70% of the patients that we are talking with are having issues for an adverse alcohol event. It's not opioids that they are seeing in the emergency departments across the section of our state. In addition, I want to mention that methamphetamine is dangerously and rapidly coming back, not only in the fatality of the overdoses. It's interesting when you look at the treatment admissions from 2019, pre-pandemic, we had 72,000 people enter the public system for some kind of treatment intervention paid for by Medicaid, Healthy Michigan, or Block Grant. That number has dropped by about 13,000 that we averaged last in 2020, around 63 to 65,000. Even in the midst of that significant drop, methamphetamine was the only area of misuse or dependence that saw an increase in admissions by 2,200 patients. Whereas when you look at heroin and prescription painkiller dependence as the primary substance that brought somebody into care, that dropped by 10,000. So the dynamic of what we are dealing with is continuously evolving. So not only do you have poison substance on the streets, but in terms of who is coming in for treatment for what kinds of things, that is taking a radical shift and change, which needs us then to kind of shift and change and adapt some of our strategies. So in terms of the strength and the health of the SUD provider system that works within the public safety net, I would say that while we are strained to capacity, that we continue to remain resilient and step into the gap for those who are struggling with any degree of substance use disorder or addiction. We have robust programs across this state, and creativity and innovation are constantly taking shape with new community partners wherever we go. You know, just to give you an example of how having a robust continuum of care really can work, you know, our staff in the emergency department can meet somebody who is in a crisis, who needs to get involved in a withdrawal management or a residential program. We can hand them off and get them connected to our residential program or to another residential program. If they're from our community, after they've experienced that kind of intensive service, they can then step back into our recovery center, maybe have to live in our recovery housing, have work with a therapist and a recovery coach, and really be able to then kind of connect and regain their life and maintain and sustain their recovery progress, if you will. Just to give you some example of our outcomes, in our recovery work in the hospitals, we saw over 1,300 patients across mid-Michigan. Many of these are small rural hospitals. Most of those patients that we are talking with would never walk through our treatment doors on their own for a variety of different reasons. But almost half of those folks are following up and participating in care because they want to start pursuing change. It's because we started to have those conversations. That outcome is consistent with the national benchmark that was established by Boston Medical, who created this program and who trained us when we brought this program to Michigan 7 years ago. And I can also say, as people engage in our recovery center and the way that we do business, where you're working with a therapist and a coach, is that 60% of those folks are completing their treatment. When you compare that to the state average for publicly funded outpatient, which runs around 45%, we see how a continuum of care of robust services can really help a person go through that entire episode from struggle to finding and sustaining recovery. So like many of us in any of these conversations you're probably having, you hear how the struggle of the behavioral health workforce shortage is creating a problem. You know, we are doing everything that we can to be responsive, but across the entire spectrum of the behavioral health safety net, SUD specifically is the only one that is completely privatized. So the providers of those services are private nonprofits like myself, Odyssey Village, Great Lakes Recovery Centers. What that does is puts us in an enviable position where we are all competing with the CMHs, with the hospitals, with the health systems for the same limited pool of social workers and counselors and credentialed counselors. So it just, you know, makes it a challenge because we don't have the same economic kind of funding and resources that a CMH or a health system is going to have. So this leads to growing waiting lists or you know, the failure to give the folks that are coming to us the right level of intensity and intervention if possible. And for those staff that we do have, it creates a significant burnout factor on them because they're carrying excessive caseloads while they're waiting for their vacancies to be filled next to them. I also would say that there is a good, robust, healthy tension between harm reduction and prevention or providers on the treatment side of things. That is an important and appropriate thing because you have to have both, and that tension is important for creating a both and perspective rather than an either or perspective. What I mean by that is it's important that we are figuring out as a system and as communities how we make sure that people don't die. Right? I mean, you can't recover if you're dead because you've experienced a fatal overdose from a tainted product that you thought was okay. In the same fashion, as we keep people alive, we need to make sure that we are also extending them hope and pathways to change with a strong, robust, supported system of care to move them towards sustained recovery. And so those both need to work kind of cooperatively together. And so maintaining that balance of how things are funded and prioritized is really important at your level from a macro level and working with MDHHS to make sure that we have a balanced approach of this kind of three-dimensional chess that we are trying to work in this particular space. It really doesn't serve us well if we are saving lives, but we don't have a healthy, strong recovery network to kind of connect them with. So I'm going to leave you with some closing recommendations or considerations. First of all, as stewards of the state's public SUD safety net, we really recommend and encourage you to create a clear, coordinated pathway for use of all opioid and SUD-related funding. What we mean by that is like, because of the generosity and the urgency of legislators like yourself and at the federal level, money has been pouring into our system. That has been a wonderful thing. It has created a flurry of efforts. And sometimes this creates programs that start working at cross purposes, well-intended, but sometimes cross purposes, or that are supplanting, maybe intentionally or unintentionally, we don't know, but sometimes supplanting existing state-funded services and state-supported services, which at the local level, all it does is create confusion and frustration. So it's imperative that these public dollars, including general fund dollars, are directed to existing contracted SUD providers, those that are already connected within the PIHP structure system, because those providers can be assured to you as the investors of these dollars that those providers are vetted, they're credentialed, they're licensed, they're accredited, they're accountable. They're accountable to licensing, they're accountable to MDHHS, they're accountable to PIHPs, they're accountable to you in terms of what are our costs for different services, what is the best bang for our buck, what are the outcomes that we are generating with the investment of those dollars. That's the best way you can be assured that there's a strong, healthy return on investment that you can always get, because there is that standard vetting that is an accountability that comes with that kind of monitoring. And when you work through that direction, you can know that there is strong collaborative processes that are structures that are already in place to ensure that there is not duplication of effort, but there is good coordination of resources, because most of us providers are working on those kind of coalitions together to say, you do this, we're going to do this, and we're going to kind of max out our impact through those particular processes. Secondly, I would encourage you to ensure that there is parity between the mental health and the SUD system, particularly as it relates to re-engineering the reimbursement structure. Unlike our colleagues on the CMH side of the world, where they have robust capitation, we're still stuck in a fee-for-service world. And as the pandemic showed us, fee-for-service doesn't really work when it's dependent on people kind of showing up and being present. And even though telehealth was there for a while, it's a nice complement, but it is not a replacement, particularly when you look at the equity issues that were exposed as it comes to broadband access and access to technology in both urban and rural settings. It's a complement, but it's not a replacement for what we have going on here. And while the CMHs are moving towards CCBHC and value-based payments, we're stuck in kind of an antiquated system, and we need to have a way to kind of move forward with that, because when we have stable funding, it allows us to focus on quality and outcomes and population health rather than volume. Fee-for-service, that generates quantity of activity. It doesn't guarantee you any kind of quality of outcome, because I'm not paid under those measures for having good outcomes. I am paid to see more people. And I'm not sure that that's necessarily what you want out of this system. So we are just encouraging you to take a strong look at that with the department. Thirdly, we want to increase administrative efficiencies and looking at reducing the paperwork burden. I think that's a universal no, and I'm not going to belabor that point a whole lot, other than to say, you know, many of us contract with multiple PIHPs. Each PIHP has their own little tweak on how they enact the same master contract that they're all accountable to. But what that means is that for providers like myself and Odyssey Village and Great Lakes Recovery Centers, we have to have the capacity to kind of shift, like, oh, this funding is from this particular region, and so they want these box checked, and this organization wants it done a little bit differently, and that just creates a lot of burden on us. And it falls a lot of times on the clinicians, because then they have to do all of these mounds of paperwork. And when you compare what like commercial health plans require from a documentation standpoint to the public system, we have to really make sure that what we're gathering really makes sense. And is it adding value to things? And if not, then let's scrub it and move forward and simplify and move things there. Lastly, we want to leave you, or I want to leave you with, from a resource needed standpoint, an encouraging thing. Recently, the department, for the first time in my 20 years, put out an infrastructure grant that allowed for us to, it was a competitive bid process, which is fine. I would much rather compete with Ronnie and know that we're on an equal playing field for our needs. But that's the first time the department has ever put out an opportunity to secure funds for technology and for facilities and things like that. And so many of us operate on such thin margins because of this fee-for-service environment that we're in. The last thing that we're able to often invest in is that infrastructure stuff. So what I would suggest is, if there is a way to work with the department to say, let's use department dollars and even maybe general fund dollars for special projects to go into some kind of venture capital fund that can look at innovation and integration, where people then can submit their ideas, almost like a Shark Tank for the public sector, if you will. But then there is equal equity, because not all of us have the same kind of connections to get special projects supported. And so from an equity standpoint, having something like that kind of fund that all of us could pitch our ideas to could bring forward some unique ways that different partners could bring ideas to the state system and look at ways that we could manage things differently. I got a whole host of bullet points on there and why that's a good idea, but I'm gonna, I know I've been talking a long time and I need to yield some time to Ronnie and Greg. Thank you for my comments.
Thank you, Sam. We really appreciate it. I did forget to say at the beginning, if we can kind of keep comments to about 10 minutes.
Yeah, sorry.
No, it's okay. It's my fault. I didn't say it at the beginning because
Yeah, we're on
folks
a
usually
time
have
schedule.
questions.
Yes.
And so we want to be able to have time to ask
apologize.
questions as well. Ronnie, the floor is yours.
Hi, my name is Ronnie Tyson. I'm with Flint Saginaw Port here on Odyssey House. We've been around since 1972. We offer a full continuum of care from detox all the way to recovery housing. We're a little different in terms of we offer what is known as long-term residential in a therapeutic community setting. We believe in this idea that relational integrity builds people's recovery capital and moves people from active substance use disorder to recovery. We stay involved in their lives for about a 5-year period, minimum. I actually graduated from the program back in 1997, and they're still involved in my life. I'm a director at the program, but they still hold me accountable to a standard. And by holding me accountable to a recovery standard, right, I get to role model this behavior for members of this therapeutic community. And I think that's what we're trying to get back to, folks, where people are building on this idea of recovery. I had the pleasure of participating in the Transformation Steering Committee for a number of years at the department. I got to learn from Mr. Larry Scott, Ms. Angie Smith Butterworth, from Sam, from a number of people in the room, how the system works. I'm an advocate of recovery. We have about 42 individuals that identify as recovery coaches in our system that work for us as recovery coaches. I mean, that's a potential answer to this workforce shortage that I heard Sam talking about. Those folks would love to be developed, if you will, into future counselors, just like I did. I got my master's degree at Michigan State University, go Green. I'm currently working on my doctorate at a place called Cummings Graduate Institute. We need to figure out how to get some of the resources that we're spending and invest them into the people that are actually receiving the services in the system. And if we can figure that piece out, then you're developing people professionally, personally, and professionally. That's the long-term solution, right? Building people. And that's what Odyssey House has been about. That's what Sam is about. That's what Greg is about. That's what we all should be about, right? Restoring community. I think that's pretty much all I have for you.
Thank you so much. Greg, we'll move to you. Thanks for joining us online. Greetings from the Lower Peninsula.
Yes, thank you very much, Chairperson Brabeck and members of the committee. So I'm Greg Toutant, CEO for Great Lakes Recovery Centers. I've been with Great Lakes for 23 years, so I've seen a lot of ups and downs in terms of the field and the industry. Our service delivery system here, we impact all 15 counties in the UP. We have about 200 employees, just to give you an idea of the scope of our agency. We operate 4 residential treatment facilities and the only adolescent residential treatment facility north of Clare. A lot of what we do around residential care is also advocating for our children. Oftentimes they are lost in the void of the entire SUD discussion. We have about 10 outpatient clinic locations. We do crisis services, prevention programming. We're the only detox provider in 15 counties. We've been a grassroots organization that looks at the gaps in various communities and what we do to help. A lot of our clinics are micro clinics, very small. As you know, for many of you that have a good knowledge base of the UP, we're exceptionally rural and we're limited in a lot of ways, but we're also very creative here in the UP. Some of the things I thought both Sam and Ronnie did an eloquent job of outlining a lot of the issues and overview pieces, so I won't go over a lot of those other than I'll point out again, the drug poisoning crisis is certainly something that is very real here as well. Our number one drug of abuse still is alcohol. And we appreciate the funding that's been given for opioid-related programming and initiatives. But what we see is the cross impact of not only meth and stimulant issues, synthetics, but alcohol as well has been critical. What we've seen to be effective strategies that we'd love to get additional support for, recovery housing. I think both gentlemen did a great job of articulating the continuum of care that's needed in the state of Michigan. The longer a person's in an entire episode of care, the greater propensity for success for long-term recovery. Those extender services around recovery housing, peer supports, case management helps to augment outpatient treatment, residential treatment, and detox. So it's important to help strengthen with a dedicated funding structure for recovery housing. And that's extremely important. The rise of the normalization of cannabis also is something that I don't think a lot of people are talking about. We've seen it being proliferated in terms of our general community use. What is going to happen long term, we're really kind of afraid here on the long term exposure, especially for our young people, in terms of the amount and scope of cannabis. I know we'll be pressed for time, and so my 2 points I think that I'd love to also get across is going to be that in 2013 or so, the coordinating agency system that used to be our delivery system for funding was transitioned and integrated into the prepaid inpatient health plan concept. We really lost a lot of the voice for those people that are receiving addiction care because we've been put towards the CMH system. We are not a CMH. Our folks are mild to moderate with some exacerbated episodes of chronic conditions. And so with the burden of not only the same requirements often that are imposed upon us that are done so with CMHs, we don't have the same funding mechanism. I'd love to talk to you more about the epidemiology of addiction and what we can do for programming, but so often it's the fight for survival on funding for our clients that's been devastated. So the 10 prepaid inpatient health plans have all 10 different approaches for credentialing and contracting and looking at the administrative burden to that. It is overwhelming for a lot of us that are statewide providers, especially those that are very rural challenged. And so if anything, the streamlining that could be done, the efficiencies that could be done with reducing how things are being distributed is very much critical. Rate setting is not universal amongst these 10 pre-IHPs for the publicly funded safety net services. So we'd really love to partner and envision what could be done to help with a different delivery model that could provide equity and parity with our colleagues that are on the CMH side of the aisle. What we do know is that fee for service doesn't work, and it doesn't work in rural areas when we have very limited volume pieces, but we're trying to provide effective long-term care approaches. Anything that can be done with different approaches for that, we'd love to be able to champion and talk more with the department and the legislature around that. And so with that, the dollars also for training for workforce that Ron and Sam had talked about, real student loan relief for the workforce. A lot has been provided to medical providers and nursing shortages, and all those are important. But direct care workers for student loan relief, addiction counselors for student loan relief, and others, it doesn't quite trickle down to a level that makes an impact of getting folks newly out of school into working long-term in our field. So I could ramble on forever. I don't want to be respectful of your time. I appreciate the effort to have a voice to deliver a few things to you today.
Thanks so much, Greg. I really appreciate that. Colleagues, any questions for our presenters right now? I have a couple. Oh, good. Rep. Reingans.
I was trying to let other folks ask questions. I'm Rep. Carrie Reingans. I used to work in Michigan Department of Health and Human Services in the addiction, and the name has changed many times, but I was focused on provider capacity in the substance use disorder treatment and recovery space. So hearing many familiar things. And one thing that was mentioned that I want to make sure everybody understands is the way the financing works for substance use disorder treatment and recovery services through Medicaid. There are many contracts from the prepaid inpatient health plans to the multiple providers. Some providers cross multiple regions, and so you have to have multiple different kinds of contracts. And they might be different in different places, and some things might be covered in different ways. So it is, for a provider, it does have layers of complexity that can be a lot to manage. And then for a patient who just goes down the road and is suddenly in a different region, it can also be difficult for them if they're, in recovery and wanting to have a job that's somewhere else, and then they move there. Now their services might be different because they're in a different region. This is a complex system, and I know that you're doing your absolute best to continue folks in supporting them in their recovery. So my question is really just about, you talked about innovation, you talked about moving toward more health home models. Is there some sort of more streamlined way you can think of that we could integrate services? Because many people with substance use disorders also have other health conditions. So we can't just treat them in this one system with only this one medical condition. Are there other models that you would recommend? You might recommend, or you mentioned health homes. Is there anything else that you could think of that would be useful, or other suggestions at the systems level?
There's some work out there called the collaborative care model, and I can't think of the name of the author. Having primary care and behavioral health do more collaboration around patient care. One of the things that I think would simplify it, the 10 PIHPs, many of them use the same software provider for their access systems. In other words, for us to get our authorizations. If there was a way for them to work together, it's the same software provider. So it looks like there should be some communication across those PIHPs, at least. And it's not presently, but that's a simple solution that would create the ability for that risk stratification, population health, where we could do a better job of coordinating our services.
Mm-hmm.
Yeah.
Thank you.
And to add on that, those are great points. Just to clarify as well, a couple of their options. The Certified Community Behavioral Health Clinics, CCBHCs, there are none in any rural corridor of the state of Michigan. That population health-based model that's about holistic care to treat all the additional related issues that people have when they're seeking addiction care and who are comorbid with other disorders, how that system could help to be expanded and really partnered more significantly with the state could be of real benefit for integration. The health plans, because as you know as well as you've hit on it, is that it is a complex funding matrix that we have. All of our publicly funded Medicaid consumers that are mild to moderate, their health care is delivered through private health plans. The PIHPs deliver the benefit and the funding and the contractual requirements for SUD programming. So we have a bifurcated system for whole person care. There are strategies that can be done at a service level and a funding level that could help bridge that gap to better whole person care. And so I think integration committees and integration opportunities between health plans and PIHPs and providers could help strengthen that holistic approach. And behavioral health homes and CCBHCs could be really good steps to further that cause.
Thank you. I want to point out there are some CCBHCs that serve geographies that contain rural areas. I think there is a phrase in the Healthcare Resources Services Administration when they look at health professional shortage areas. There are rural areas, and then there are what they call frontier. Almost all of Alaska is frontier, and almost all of the UP of Michigan is considered frontier. So it is like a rural on top of rural type of designation. So I there are no CCBHCs in frontier areas. I would say. So sorry.
To add to that, I just had the opportunity to talk with colleagues from across the country, and I got to talk with a CCBHC director who is her whole area, it's in Minnesota, is frontier as well. And so I was really grateful to be able to talk with her about how this integration works in that in the frontier setting.
Rep. Braybeck, another comment I would make about, this is a little bit different from CCBHC, but another comment about the bifurcated system. I think Michigan was one of the first states to carve out, and one of the states that still maintains the carve out of our behavioral health services, in part because the management of a population with behavioral health conditions has a different kind of management of those conditions than of some physical health conditions that have a different kind of research in the treatment of those conditions. So many conditions that are in the physical health space have years of clinical research about typically a knee surgery takes this much time to do the surgery, this much recovery, this much physical therapy, this much medication to manage the pain, and it's like roughly known that this is what it's going to take, kind of from start to finish. With mental health conditions, substance use disorder and addiction, there's people who have higher levels of need, lower levels of need. You never know how long it's going to take for them to get the first time they walk in the door and to maintain sustained recovery. And I'm talking years. And so it's really hard to look at that population and say, oh, well, we can manage it into savings, and we can make this into a population where we know the treatment, the timeline, and we can bundle the payment, and we can really save a lot of money by managing this population. It's just you don't treat the conditions the same way. You have to be, and I mean, you said you have folks in there for 5 years or more. Mm-hmm. So like, how do you look at that as a trying to manage that population and look at the actuarial studies and figure out how to actually manage that down for savings? It's really difficult, and that's a way that I understand why we have a bifurcated system at this time, though it does seem to be having room for improvement for the patient who has to go to different places and have different payers. It is complicated.
And if I can just add on to that in terms of the need for that kind of population health perspective, for a person to get 1 year of continuous recovery, it takes them 8 years of trying and 3 to 5 treatment episodes to get that first year. But it's not until I've had 5 years of continuous recovery that my remission rate falls to kind of the normative level that we're all at risk for. So we're talking about a 13-year episode of care or system that can be responsive to those needs in that journey. So to your point, structurally, things have to be able to change to be able to manage that chronic condition for so many of the folks that get into the mild to moderate or comorbid physical ailments because of their chronic use. Thank you.
Rep. Edwards.
Good morning. So my question, I'm just going to make my question short because of time, but I really just want to thank all the presenters that share information on the workforce shortage, because we know that there's a lot of different programs that are available. We don't have workers that are able or willing to even work in those areas due to the amount that they get paid. So I would love to extend the invitation to those individuals that presented to contact my office, because we are working on ways to make individuals or make it interesting for people to want to go into social work or counseling, and also provide those incentives where we can reduce the amount that they pay in their student loan debts, or make it where it's not a financial burden if they go into those fields. So it's not a question, but I would love to follow up and meet with those individuals to figure out what strategies they've already worked on.
Great, thank you, Rep. Edwards, we'll make sure that you have contact info for folks, and make sure that you all get Rep. Edwards' contact info as well. Thank you to all of you. Greg, thank you. Thanks again for joining us from the UP. Ronnie and Sam, thank you so much. We appreciate you all being here.
Thank you.
Absolutely. So next, we will have Linda Davis join us. Linda is the executive director from FAN, or Families Against Narcotics, and serve folks from lots of different places, but primarily Macomb and Washtenaw. Is that right? We're still, okay, sorry, when I was looking at my apologies. So you go ahead and take it over, because you can talk much better than I can about you.
Today to talk about our services and to address some of the issues that you've brought up as well. Oh, my apologies. Okay, all right. As I've already been introduced, I'm Linda Davis. I am the executive director of FAN. I've had a long history with substance use. I was a school teacher for 13 years. Don't add these years up. I was a prosecutor for 13 years, and I was a district court judge who ran a successful drug court for 19 years. And so I have dealt with substance use disorder throughout my entire life. What brought me to do this work full time is 17 years ago, I had my own experience with addiction in my family. I had a young daughter I was raising, an excellent student, an athlete, who ended up having a knee surgery and became addicted to Vicodin, which led to a heroin addiction because she was too ashamed to tell us that she had become addicted to prescription drugs. It was a 3-year battle, and believe me, a lot of the things that Sam and Greg and people that have addressed here today were exactly the reason why I got into this space. I never could find treatment for my daughter in the state of Michigan. Our bifurcated services here almost allowed her to die. And I had to look outside of the state to find sustainable treatment for her that was long-term continuum of care services that eventually led to her getting well and maintaining sobriety for the last 14 years. So I am one of the lucky parents, but the devastation that I went through the entire system after 4 hours of calling treatment facilities and trying to work within the systems in Michigan, being a judge with lots of pull, I could not navigate the system, and so I wanted to create systems that were easier to navigate to help people find recovery. And so our organization was started 15 years ago by a number of families who went through exactly what I went through. Were very frustrated with the system and just wanted to, number one, educate our community about what our young people were going through, and then provide services that would be warm handoff programming that would help people access treatment. I could not imagine having to be a person whose mind had been affected by drugs and navigating the system that we have set up in Michigan to do that. So those warm handoff programs are really necessary. I'm going to talk a little bit about what we do, and then I'd like to address some of the issues that were brought up by some of your committee members, if I might. So we started out highly as an education and prevention network in the very beginning. We were all a volunteer. We are a 501c3. We are licensed through the state of Michigan, and we are working on accreditation. We've only been funded for the last 4 years, but we are in the process of working on our accreditation, and hopefully over the next several months we'll be accredited through CARF crediting. So we are working in that direction. We have been funded by the legislature for the last 2 years and by DHHS. A lot of our funding comes directly from DHHS. We provide education throughout the state of Michigan. We started in Macomb County. That's where our roots were at. But we quickly spread to other communities. Once we started talking about this problem, more and more people were saying, we want to educate in our community too. We presently have 23 chapters throughout the state of Michigan, through the Upper Peninsula, west side of the state, but predominantly, a lot of our work does take place in the Tri-County area. But we have expanded. We have a strong presence in many other communities throughout the state as well. I want to indicate to you that we only go where we're asked to go. So we are filling gaps throughout the state of Michigan. We have a program called Hope Not Handcuffs that is a police-oriented programming where you can walk into any police station that works with us. We presently work with 130 police departments, and we have 19 that are waiting to start depending on what our funding is next week. You can walk into any one of those police departments, just merely state that you are suffering from any substance use problem. We disperse a volunteer angel to that police department. We now have a call center because we have been fielding so many calls over the last couple of years that we had to develop a call system. You call from the police department to our call center. They then connect with the appropriate PIHP provider, and then we begin the process. I want to reiterate that it is a monumental job. Running an organization like this with 10 different funding streams that people go through. So that has been a very difficult, we literally have volumes of manuals how to navigate each one of those PIHP systems. But we've successfully been able to do that and to place many, many people into treatment. Our Hope Not Handcuff program has been up and running. It was patterned after a best practice program out of Boston. We have received nationwide accreditation for that program as far as the efficacy of our program and the volume and how well run that program is. People walk into a police department, like I said, not only are they connected with a treatment provider at that point, we then assign a peer recovery coach to that individual. We stay with them, we visit them while they're in treatment. When they come out of treatment, we make sure that they have sober living housing. We provide transportation to the treatment provider, which is a huge gap in care for individuals, is just not having transportation. We provide that through our agency to get people into treatment. We then pay for sober living so that when they're coming out of treatment, there's oftentimes a gap in services that exist there. So we will pay for the first 2 weeks and in extreme cases 4 weeks for sober living scholarships so that individuals can stay on their journey to recovery. We then provide services also for the family. We oftentimes talk about addiction being a family disease, but rarely do we ever include the family in the treatment protocol. We have developed programming for families. We have peer coaches that are family members, much like myself, that have gone through a lot of education and programming and other family groups throughout the United States. And we provide one-on-one coaching for parents so that they promote recovery of their loved one rather than enabling them to stay in their addiction. We also have a 12-step educational program called Stronger Together that is offered virtually as well as in person throughout the state of Michigan, which are 12 steps educationally that parents need to know when dealing with a loved one with addiction. We also I wanted to indicate that since 2017, we have placed and stayed with over 10,000 people that have been placed into treatment through the Hope Not Handcuff program. And we do stay with and monitor those people for a minimum of 1 year. And if necessary, we stay with them longer. And that will lead me to a discussion of what you brought up earlier about the healthcare system model. Our Hope Not Handcuff program continues to grow. We also have Hope Not Handcuffs in the state of New York. It is not funded by Michigan money. They get their own funding from the state of New York, and we work with 69 police departments in the state of New York doing that programming as well. We also do naloxone training. We have a very robust naloxone training that takes place. We work with a lot of universities on that programming, and we put naloxone into the hands of everybody that comes through our programming. I wanted to indicate that, You know, I'm really amazed at the number of providers that you had here today, and they all do incredible work. But when you stop to think about, we are only really servicing 11 to 12%, depending on which studies you read, of the people that suffer from substance use problems. We really need more providers and to expand the providers that are doing this incredible work in the community. Across the nation, and I would call all of these programs boots on the ground programs that are dealing with people where they're at, that is really going to be what changes the landscape and the success that we have with programming. I think that all of us realize that that continuum of care is what's been missing. And the reason we can't study how long it takes a person in recovery, and when you stop and think about what Sam said about how many years of recovery you have to get that 1 year, it's because we have a one and done system of care where we send people to treatment and then there's no follow-up. We would never do that with another disease, and so we can't study how long it would take if we don't have a good system of care set up to begin with. And so we really need to fund organizations that are doing that continuum of care and do pilot programs with them to see what kind of success they have and how many times does it take going to treatment if you're provided all that follow-up care that we do for diseases like cancer and diabetes. We can't just keep doing one-and-done programs because it is wasting valuable dollars that come into the state to provide treatment for individuals. We try to look at where are we missing people. We have close to 90% of the people that never access treatment. So our Hope Not Handcuffed program was one of those programs. Let's make it easy for people to go ask for help. But we're aware of the fact that not everybody is comfortable walking into a police department to ask for help. So we do have a Hope line that you can call that will access you to our call center right off the bat, and we can do that over the phone for you. But we also have a Comeback Quick Response team that was funded through DHHS. We were asked to pilot that program as an initial program in the state of Michigan. We respond to an overdose within 72 hours by taking a police officer, a peer recovery coach, and a family coach right to the house of the individual that is suffering from substance use disorder. We know that they are vulnerable for death. If they've overdosed once, it's very likely that they will overdose again. And so we want to catch those people and be preventative. It is really amazing to see the police departments that work with that programming. It has been highly successful, that now they are doing it as a preventative measure. They are actually going back through their caseloads, and they are aware of who's using drugs in their community. They will add people that they know are still using substances but haven't overdosed yet. We add them to the calls that we go out and make as well, so that we catch them before they overdose. We shouldn't have to wait for a tragedy to occur in somebody's life to offer them help. In addition to that, MDOC, Michigan Department of Corrections, has partnered with us in many communities that we do quick response team programming, where they will, when somebody is placed on parole, they will put them on our call list, and we will do a wellness check on them to make sure that they are not relapsing and going back into their substance use. And then they are doing preventative things of, rather than incarcerating them, if they see they're slipping, we place them into services, we get them back into treatment, we get a peer recovery coach assigned to them, and we are seeing that that is keeping them out of the prison system and is extending their length of sobriety. In addition to that, we have a harmless program, which is a harm reduction program. It is a safe syringe program, but is so much more than that. We talked about the need for more people in the space of healthcare providing these services. So we have partnered with Michigan osteopathic students as well, under the leadership of a doctor, obviously, and also with McLaren's residency program. We actually do a street medicine program with our harm reduction program. And it is really amazing because these are our young doctors and residents that really had no desire to do substance use treatment. But once they're out in the street and they start seeing that They have a real stigma about addiction, and that these are really just people like you and me that are very sick and in need of help. Many of them are saying, you know, I never thought I would want a career in substance use, but that's exactly what I want to do. That program has been it's one of my favorite programs that we do, because seeing the successes of that program are just unbelievable. We do wound care. We were called upon by McLaren to do a program like this because their ERs were inundated with people that were coming in for wound care from injection site abscesses. And so we started doing those out on the street, so it has been a real relief. And we have done studies on the amount of money that it is saving the ERs for every person. And in one corner of Macomb County, we have serviced close to 4,000 individuals there. Over 1,200 of those people have received health care services from our street medicine program. And we have been able to track through the doctors' help with that program that for every patient we service out on the street, we are saving $9,000 in costs in the health care system. So there is a real need for that street medicine programming to be expanded and to be funded more robustly throughout the state of Michigan. Just to give you an example of that program, I had a young man who had been in my drug court that went missing. He was missing in action, and we were really never able to connect him with appropriate services. He showed up at our Harmless van to receive medical care one day. He had been living on the street for 3 years since he had absconded from drug court and had been injecting in his neck and had to have neck surgery. He was still living on the street after that surgery, and because we don't have a medical model for substance use, he was sent right back out onto the street to live and did not have a lot of follow-up services that followed him with that. Well, the wound became infected, and by the time he came to our van, he had an abscess on the back of his neck that was about the size of a tennis ball. We literally had to cut his shirt off of him to get a good look at it. He did not want to go to a hospital. He said he's treated so rudely and disrespectfully that he just can't stand it, and that they'll just patch him up and send him back on his way again. Well, we got one of our doctors that is involved in our street medicine team to come out to the site. It was beyond what students could handle at that point. He drove out to our site and tended to this young man, told him he needed to go to the hospital, but he would stay with him and make sure that he was treated respectfully throughout that process. The young man received medical care. They said he would have died within 24 to 36 hours if he had not been taken there. And the amazing part about that is because he was part of that program and we were connecting him with other services while he was receiving harm reduction, he has now maintained over 1 year of sobriety and is doing well and has a well-paying job for the first time in his life. Programs like this work, but they take funding and they take a lot of individualized hard work to make that kind of miracle happen in the lives of individuals. Our harm reduction program is growing. We have been told by the Michigan Department of Health and Human Services that they hope to help us expand that programming. So we are hoping to do that in other high needs area throughout Michigan as well. And we started last year a redirect program, which is a diversion program from jail. That is only in Macomb County right now, but we are expanding to other counties this year, depending on our funding, obviously. But that is a program where someone is arrested for a low-level drug crime or theft crime like retail fraud, and it's obvious to the police officer that is a substance use problem involved here. They do not arrest that individual. They divert them to our program, which is a case management program. We actually have social workers that are working with those individuals to give them individual care. These are usually people that are homeless. They are also people that have been through the system numerous times and are not able to do traditional probation. And we we are able to divert them, give them one-on-one services, connect them with peer recovery coaching, and it takes some time with individuals like that, but we are already seeing the fruits of that labor, that if you treat individuals with compassion and the right kind of care, eventually they find their way to recovery. I want to say that with programs like Redirect, you are dealing with probably the most difficult populations with the Redirect program and the Comeback Quick Response Team programs, and yet we are able to see massive success with those programs when we provide compassionate care, not requiring abstinence right from the very beginning, but knowing that those programs will lead to abstinence. People are 5 times more likely to reach out for recovery services when they are treated compassionately and given the appropriate care right from the minute they walk through the door. So that is our programming in a nutshell. It's a lot of work in a very short period of time. But I did want to address your question about systems of care. I really do believe, and I know it's difficult because of all of the reasons you said, but we have a lot of good agencies that are doing continuums of care. You've heard from several of them today. That if there were pilot programs where we were really able to provide a very robust continuum of care, and I'll liken that to drug courts. We do that with drug courts where people see those people regularly. They are placed in inpatient. They are provided outpatient services. They are checked in with regularly. They are provided with peer recovery coaches. Their families are worked with. That we see tremendous success with that population of individuals because we've provided that continuum of care. If we could take that into agencies that are boots on the ground agencies and pilot programs, I believe that we could start establishing the benchmarks that you're talking about to be able to show that the healthcare community, that there could be savings and that this is a population that they can help. It's really time for us to quit treating substance use as something other than a disease. A lot of the stigma around addiction comes from the way our system of care works with individuals. If we are going to treat them as though they are moral failures and not provide a continuum of care for them that ensures their success, we really are sending a message to the individuals suffering from this disease and their families that we really don't care about this population of people. We really need to do better. It is an abomination, the system of care that we have for individuals with substance use problems, and we really need to work to do better. And I believe that there are solutions to this, but we need to get like minds to come together and realize that we shouldn't have to compete to do this work, because there is plenty of it to go around, and that we should be working together to make sure that we stretch our dollars as far as they can go, and that we provide a continuum of care to individuals that will show that 1 year of care can lead somebody successfully into a life of recovery.
Thank you.
You're very welcome.
We really appreciate it.
Thank you.
We have some questions, but we also have one more presenter.
Okay.
And so I'm just aware of the time because we have a
Okay.
hard stop at 10:30. Rep. Pahutsky.
Thank you, Madam Chair. I'll be brief. First off, thank you. My community has done a lot of work with your organization, so I appreciate the work that you do there and you coming here to talk to us. I know that you had mentioned in the aftermath of an overdose, folks will go out and connect and try and get people into help, which, like I said, you all have done amazing work, both on your own and partnered with groups like GrowthWorks back home. So I understand that. You said that a law enforcement officer goes out with you on those calls. Is that in every case?
It is for us.
Okay.
We are starting to work with EMS in other jurisdictions. One of the EMS teams reached out to us and said they would like to start partnering with us. And we also work with fire departments. So it changes a little bit on who that person is going to be that go out. But originally when we started, we do have 20 police departments. They are dressed in plain clothes. We leave a card at the overdose indicating that they are coming back, that they don't need to fear arrest, that they had a life-altering thing that just happened to them that is very dangerous for them, and that we are going to come back and just do a wellness check to make sure they're okay and to see if there's anything we can do to help. The police officer actually makes the introduction, and it was really amazing because even they thought we're going to get doors slammed in our face. That has never happened.
Yeah.
The people are so amazed that a law enforcement officer is there to help them that they are actually very welcoming. Our bigger problem is that oftentimes the person that is using is very transient and isn't always at that house. But we keep going back until we find them. We don't give up on individuals.
No, that's great. So then is the purpose of the law enforcement officer there for your safety, or I guess what was the impetus for bringing law enforcement out to begin with?
Mainly because it reduces their stigma about addiction, and we want them to change the way they do things as well.
Sure.
And it's also the same concept of the Hope Not Handcuffed program. When the police officer in Boston opened his doors, it was really the comments from people that went through that program is that law enforcement person telling them they wanted to see them get better. Really, it's kind of like the drug court concept, is that person in authority caring about them really can change and be an incentive for people to take the next step toward recovery. And we see that works because even when people don't take help at the door, it's amazing how many of them will walk back into a police department after that to ask for help. So it's working.
Great, thank you.
Okay, sure.
Colleagues, I'm going to ask that your questions be very, very short because we still have one more presenter. I'm sorry, Minorities Rights Chair Smalls. I'm looking right at you. Like, go ahead.
Thank you, Madam Chair. I do that. That's okay. I was waiting for it. Thank you for your testimony, and thank you to everyone for all your testimony today. It's always nice to hear so many people trying to help others who really need help. I agree the collaboration needs to be more between groups, and also the follow-up care. That's so important. We have to do more in that area. I love this Hope Not Handcuffs program. I think it's important you're talking about the relationship with the police. I think that really helps when you have a substance abuser know that the police can be there to help, and that's a good partnership. How many police departments do you work with, and do you see a big outcome, a different outcome with these patients when they do go through this Hope Not Handcuffs program?
Yes, mainly because they are asking for help. We've opened a door and they're walking in and saying, I'm ready. I will tell you that when we first started the program, it was not successful because we didn't have any money. We were doing it as volunteers. We just had angels. But when we got the funding from the state and we could add that continuum of care, the peer recovery coaches, just getting them into treatment was not working. They'd come back out and they would relapse again. But once we were able to add the family coaches, the recovery coaches, the scholarship program, we are seeing about a 70% success rate of people that come through that program.
And how many police departments do you work with right now?
We work with 130 right now, with 19 that are waiting in the wings to see what our funding is going to be like next year.
Okay, thank you.
Okay.
Thank you.
Okay.
Thank you so much,
Thank
Linda.
you.
We really appreciate you being here and offering your perspective. It's fantastic. Thanks for
Okay,
what
thank
you
you
do.
so much. I appreciate the opportunity.
Absolutely. So next, as I said, he's our anchor today. So we have Dr. Asabiji, who is here with us. He is the vice president of the Detroit Recovery Project, and he's also a member of the Michigan Association of Substance Abuse Providers. Oh, hey, Claudia, could you help with that, please? Thanks, Thomas. We're glad you're here. We have probably about 7 minutes to hear from you, and then I want to be able to offer some time if my colleagues have any questions, because we have a committee that starts here at 10:30.
Okay.
Welcome.
Thank you very much, Chair and Representative Brayback, and thank you very much to the committee members. I'm Kanzoni Asabiji from Detroit Recovery Project, and also representing the Michigan Association of Substance Addiction Providers. We've expanded our name, excuse me. We were just limited to Wayne County, but now we expanded our name to be statewide. We were formed in 2014 because during the merger of the coordinating agencies with the mental health agencies, SUD did not have a voice. I was the former director of the coordinating agency for the city of Detroit, and we just didn't have any input whatsoever when decisions were made because of the huge disparity in the funding. The mental health at that point had almost 800 million for Wayne County, and for SUD it was only 30 million. So you could just see the big difference there and how the merger occurred. So I'll just briefly summarize what has already been talked about. We represent a variety of providers providing prevention, treatment, detox, residential, intensive outpatient, domicile, medication-assisted treatment, crisis intervention, outpatient, and recovery support services to youth all the way to seniors. Our challenge as a network, our group of providers, is that with the overdose, opioid overdoses, we've seen some challenges with individuals needing treatment. And some of those challenges include transportation issues, lack of transportation or inadequate transportation, lack of telehealth or inadequate telehealth, and then, sometimes they have to wait for 14 days in order to get into treatment. We'd like to see, treatment on demand, because when somebody suffering from this disease of substance use disorder needs treatment, they show up, this is the time for them to get into treatment. Telling them to go and come back another day might just not be enough. They may not even make it the next day. So we'd like to see some improvement there. And we'll also have seen data just indicating that, the jails and prisons and emergency rooms are frequently overused by individuals suffering from substance use disorders. And so this is a really serious problem for us. The reimbursement disparities, just give some examples. For the same service for mental health, they get reimbursed at a higher rate than for SUD. So for example, medical eval for mental health, they get paid a lot higher than SUD psych eval. But SUD providers are paid, 37.5% less than, their counterpart in the mental health division. And also for groups, the same thing. We get paid, sometimes up to 50% less than the other mental health professionals. So we'd like to see some, parity and also attract people to come in, into this field. That takes me to the next highlight here, workforce shortage, and some of the previous speakers discussed this issue. We have significant difficulties attracting people, licensed clinicians to come and provide this service. One, they encounter a lot of trauma just dealing with, everyday situations and clients, and the reimbursement is not sufficient for them. So we'd like to see a lot more efforts and support in trying to attract people to provide, get into SUD and provide these services. Next item I would like to just briefly talk about is credentialing. So we've had, it's improved, but for recovery support services where we've seen that they've made a significant differences by recovery coaches and mentors, we have two-tier systems. We have the latter certification through MDHHS for mental health, and then we have MACBAP, the Michigan Certification of Addiction Professionals, also, providing certification for that. We'd like to see those merged together and also just figure out a way to make the credentialing a little bit easier for these individuals to participate in the workforce. They are subjected to a lot of tests and exams, but from my experience, individuals, the people that we serve, have 75 to 80% have high school diploma or less. So it becomes a challenge, but they have a lot of experience, in recovery. So they have done certain things well to be in recovery for 5, 10, 30 years. That accounts for something really good, and we've seen the outcome. They are able to help people, prevent them from, recidivism, going back to the emergency room more frequently. So that's really something that we would like to, assistance to address and make it easier for individuals to participate, and also to try to remove some of these barriers. The opioid settlement, the governor set up an opioid advisory commission, and they produced a report. It contains some good recommendations, so we strongly urge you to, support some of these recommendations. In closing, I handed out some printouts just showing, and this is from the University of Michigan Injury Center. So you can see suspected related fatalities for Wayne County alone for 1 year, just this month, May 19, back to May 2023 to May 2020. And this information is gotten from the medical examiner. So you can see that, we had 904 suspected overdoses, fatalities. This is really high, very, very high, and we can do something about it. And one of the, this is good information as an epidemiologist also, we now, I would say, a better real-time assessment of what the needs are and what the epidemic, what is happening in the field. Because in prior years, we used to wait for 2-3 years to get this information. And by that time, we've already lost a lot of people. So 90% of this is also, usually confirmed because it takes some time for the lab to confirm the fatalities, and we suspect the majority of them are fentanyl related. The other piece also gives us a guide about the overdoses, and this is from the EMS runs in Wayne County, and this is also from the University of Michigan Injury Center. So it gives a picture of, almost 4,500 overdose, Narcan administration. Not all of them are drug-related, because if somebody is not responding, they don't know, they automatically administer Narcan, just to see what would happen. But in our experience, we see that over 80% of them usually are, drug overdose related. And so it gives us a really good picture of what's going on. And we can also drill this down to the zip code level and work with community-based organizations to address these issues. Thank you.
Thank you so much, Dr. Asabichi. I really appreciate it. Rep. Reinigens, super fast.
Yep, one clarification, Dr. Asabichi, thank you so much for being here. The Michigan Opioid Advisory Commission is part of the Legislative Council. Okay. So that was created through law last fall by the legislators, creating this in the Legislative Council. The governor's task force you mentioned was created by executive order in 2019 to reduce overdose deaths by half by 2025, and that is a different group. So it's confusing, but I do encourage my colleagues to look at the commission report, because there are things for us as policymakers to do.
Yes, thank you very much for.
Dr. SBJ, I really appreciate it. I know I have some questions that I'm going to follow up with you afterwards, particularly about Cloxato and use around that, and I just have some questions. But team, thanks so much. I think we have some work to do in terms of looking at both the continuum of care, how we do that, funding mechanisms so that funding is clear, and we don't have some coming from the public system, some coming directly from DHHS, like figuring out how to do all of that. And looking at these broad pictures so that we can get these services out to folks. But I appreciate your attentiveness and your questions, and I'll see you in 2 weeks where we're going to be taking up some of our first bills. Thanks, everyone. This meeting is adjourned.